Dear Professor Harbeck, dear Nadia, the San Antonio Breast Cancer Symposium 2021 was last week. What were the highlights for you for early breast cancer?
I think in early breast cancer, we saw a couple of talks discussing which would be the best endocrine therapy in young women from the Oxford meta-analysis, as well as a 12-year update from the soft and text trials. And that showed us that there is a slight advantage for an AI over tamoxifen, obviously given together with GnRH, but it depends on the risk profile. So if it's a node positive tumor, there will be a larger absolute benefit than if it's a node negative tumor. And also in the soft and text trial, for example, we saw that the benefit of additional GnRH is greater than the added value of then AI versus tamoxifen. And obviously, patients who have a low risk for relapse, they do not have um, an absolute net benefit. So I think all of these endocrine therapies, we have to discuss quality of life as well as risk for recurrence. And in my personal opinion, I always try to find something that the patient is able to take for 5 years at least. And these 1 or 2% absolute benefits, they don't translate into the clinic if the patient isn't able to take that particular medication. But interesting data. The other data we saw was on the Keynote 522 study, which is adjuvant or neoadjuvant pembrolizumab together with chemotherapy in triple negative disease. This wasn't no data. We've seen that last year at an ESMO virtual plenary in July and then at the ESMO conference. And now we saw some updated analysis showing how the benefit was very persistent over time with the PCR improvement as well as an EFS, event-free survival improvement, favoring pembrolizumab. And obviously, the benefit again was larger in node positive disease, but there's also a benefit in node negative disease.
Two questions, one to the anti-hormonal therapy. If a patient started with, let's say, GnRH and AI, an aromatase inhibitor, can they, if the quality of life is so bad, too bad under this therapy, can they switch to tamoxifen then, and the other way around as well?
Obviously, I think it's always good to sort of not try to persist on one therapy if it really isn't possible, but rather to try to offer other possibilities. So we try then tamoxifen, keep the GnRH, but if there's a lot of like postmenopausal complaints, hot flushes, and uh, dry skin and mucosa, then one could also get rid of the GnRH and try tamoxifen alone. So there's a couple of options, and I usually try to convince my patients to give each new therapy at least like 2 or 3 months to sort of see whether the body will get accustomed to it. But if it really doesn't work, one needs to de-escalate one step. And that's what I said. There is absolute benefits between like 2 and 4% for some of these drugs over the others, but that's minimal in comparison to not taking it at all and losing out on the protective effect of these endocrine therapies overall.
Thank you. And to pembrolizumab, when it was given neoadjuvant as a neoadjuvant therapy before surgery, how long uh, will it be given afterwards?
So in the study they did an anthracycline taxane plus platinum chemotherapy sequence, and pembro was given together with all of the chemotherapies, and then in the adjuvant setting it was also given in a placebo-controlled way for an additional 9 cycles. Um, we don't know which component is the more beneficial component, whether it's the neoadjuvant or the adjuvant therapy. I think we will need further trials to sort of look at that. For the time being, I think both are important. And interestingly, when we look at the improvement of event-free survival, what we see that in the PCR patients, both do well, the groups with and without pembrolizumab. But if you look at the non-PCR patients, the group that had the immune therapy still does a bit better. So I think there's a lot we don't understand about immunotherapy and whether it's better combined with chemo or given in the adjuvant setting. For the time being, I would do both. It's like in the HER2 positive setting. It's more or less a year of therapy altogether.
Okay. Thank you very much. Let's turn to the metastatic setting. We have a lot of new therapies there coming or already approved. So, what did you see at the San Antonio Breast Cancer Symposium?
There were interesting data. Some of them, as you said, we've already seen, and that also makes me a little bit proud because we see that for example, the European Oncology Conference, the ESMO conferences are gaining in importance because a lot of the data from San Antonio we had already seen at the prior ESMO meetings throughout this year. So I think that's something that we can be proud of, that the quality of care and of the science is actually very, very good here in Europe. So maybe one from the hormone receptor positive, HER2 negative setting, there was the first phase 3 data for an oral SERD compared to whatever the doctor thought was the appropriate therapy in this setting. And it showed that this oral SERD, elacestrant, was actually better than treatment of physician's care. But and it was well tolerated. So I think SERD is an estrogen receptor downregulator. Patients probably know this as fulvestrant, which we give intramuscularly once a month. And this would be great if we don't have to give these injections anymore. Whether it's going to be this compound or another compound in this class, there are lots of them being studied right now. I don't know. But what I can say is that the only downside of this study was it was done in a very late line. So the effectiveness of both the new therapy as well as the old therapies were not so great. But I'm sure if we move these new oral SERDs to an earlier setting, that their efficacy will be better.
I think an also very important point is that we, especially in the metastatic setting, we have quite a few patients that are taking blood thinner. And if they're taking blood thinner, they can't use fulvestrant. So they have a new therapy option.
Yeah, I mean, it's not approved yet, but I'm sure that the company will take this forward, and one should not be too disappointed by the overall not good efficacy in this trial because, as I said, it's a very late line. The blood thinners are a real problem. It depends on how urgent they are. Sometimes you can just leave it away the day of the injection and give the injection anyways. But in patients who have just had some cardiac problems and need the blood thinners continuously without break, we cannot put them on fulvestrant. So that's completely right.
What about the HER2 positive patients in the metastatic setting?
Yeah, that's a setting where we have very good news for patients. Nothing that was particularly striking at San Antonio, more subgroup analysis from the data that we had already seen. But we have new medications here, and we had um, for over a year already the tucatinib, which is a small TKI, an oral drug that we give together with trastuzumab and capecitabine chemotherapy in HER2 positive metastatic breast cancer after 2 prior lines of anti-HER2 therapy. And this drug is actually very active in also in brain mets. Overall, The registration trial was positive, the HER2CLIMB study, but also in patients with brain mets. And for the first time, we also have a drug here that works in patients with active brain mets, which is some brain metastasis that they had not been treated by, for example, radiotherapy. So this makes us very hopeful that we now have for the first time a drug that actually helps us in brain metastasis in HER2 positive disease, which is great.
Wonderful. I mean, I think all new therapies that are coming up now, I mean, it's so fast. The progress seems so fast at the moment. But we also have the trastuzumab deruxtecan. What about that?
That's right. We also saw an update there, and it's so fascinating see this drug with these fantastic data against TDM1, where we saw that in the Destiny Breast 3 trial that it's actually much more effective in delaying the disease and disease progression, and probably also in overall survival. And what we also saw is that it also works in brain metastases, but in patients who had treated brain metastases. So we don't know whether it actually works in the brain in untreated metastases. But again, a drug that is immediately now become the second line standard. Only problem from a German point of view is that it's not available in our country because the company has not fulfilled this health technology assessment process to give a price to the drug. But we have a trial right now in Germany. It's called Destiny 12, and it's led by Professor Wimberger in Dresden and available in a couple of sites all over Germany. So if patients are in need for this drug, also with brain metastasis, they can have their doctor contact one of the study sites, Destiny Breast 12.
Um, if the new drugs are not available yet in countries, not at all available, is TDM1 still an option for treatment?
Yes, it's a very good drug. That's why we are so excited about TDXD because it's even better. TDM1 is a fantastic drug. We use it in the early breast cancer setting in non-PCR patients, but also for the metastatic breast cancer patient. We have a patient that she's been now, I think, on 8 years on TDM1 and a couple of others who are also long-term on this drug. So it's a good drug, and everybody who is already on TDM1 should not switch unless there is disease progression. But if TDXD becomes available, it will be the new second line standard.
Sounds so exciting. And now we also have some good news for the triple negative patients.
Yes, we have two new indications actually. We have a new indication for the immunotherapies. So far in the first line setting, we had atezolizumab available, and now we also have pembrolizumab available based on the Keynote 355 studies. And again, here we didn't see new data at San Antonio, but an update given by Dr. Cortez. And here we understand that pembrolizumab together with chemotherapy improves overall survival, and the benefit is seen in patients with a PDL1 score CPS of 10 and greater, and the higher the CPS score, the greater the efficacy. So we learned that. That's for the first line setting. For the second line setting and beyond, we have saxituzumab govitecan, which is a new antibody drug conjugate. And that has been already used in the US for quite a while. And there's a registration study, it's called Ascend, and it showed that this drug is actually better than standard of care, whatever physicians wanted to give with regard to overall survival. So very exciting times. And this new drug, saxituzumab, has been approved. I think it was at the end of November in by EMA, so very, very recently.
Is it already available in Germany?
Yes, it's available, and we've already treated some patients, and it works quite well. With all of these antibody drug conjugates, we have to expect a little bit more side effects than with just antibodies. We have hematotoxicity, so blood values may change, but overall, it's tolerated quite well, and we're really looking forward to using this more often.
I think altogether with all the new therapies, we learn some new side effects and how
Yeah,
to treat them, hopefully.
of course, we know how to treat them, but I think it's more important to make doctors and also patients aware of what can happen. And we talked about TDXD, trastuzumab deruxtecan, in HER2 positive second line, and there we see some pneumonitis, which is a lung affection that is not caused by bacteria, and uh, which can be treated quite well if it's caught early by steroids. And so we have to be aware that this can happen. And it was much greater in the phase 2 study. Now in the phase 3 study in the um, breast or 3, we only have like less than the 1% of the severe um, forms of this side effect pneumonitis or ILD. So I think with proactive management, making patients and doctors aware that this can happen, and catching the first symptoms, like if patients start to cough under this treatment, get short of breath, we need to do a CT scan immediately and then treat with steroids. I think we can uh, um, manage this quite well.
Okay, and I think one of the side effects that comes almost with every new drug is diarrhea.
Yeah, it's with we see this with the TKIs, with these small molecules in HER2 positive disease. Fortunately, with tucatinib, not so much because it has less of an EGFR component. So it doesn't work on the HER receptor that causes a lot of diarrhea, but in the combination with capecitabine, there may be some problems there. And again, here, it's important to prescribe loperamide, but it's not just important to prescribe it. The patient actually has to fill the prescription and have the drug at home, because a prescription on the night table doesn't help on a Friday at midnight. So we have to see what we have to do. And for example, neratinib is also it's an older drug, but new in the indication in early breast cancer, HER2 positive. There we have learned from a second trial that if you escalate the dose until the most effective dose instead of giving the most effective dose right away, that can also help. So lots of tricks we learn while we were using the drugs, and we carefully listen to our patients and when they tell us what works and what doesn't work, because we might get some tips that are not in the publications but also very helpful.
But altogether, 2021 was, except for the COVID-19 situation all over the world, I think a good year with new drugs coming for therapies for breast cancer patients. So thank you very, very much for this interview.
My
Have
pleasure.
a have a nice Christmas and thank you.
Thank you.